From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this edition of the JAMA Clinical Reviews podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. Gbenga Ogedegbe, the inaugural and founding director of the Institute for Excellence in Health Equity at NYU Langone Health. He is the Dr. Adolf and Margaret Berger Professor of Medicine and Population Health at NYU Grossman School of Medicine, and he is a member of the National Academies of Medicine. Dr. Ogedegbe is a general internist, and he is also a member of the U.S. Preventive Services Task Force. And this week, JAMA publishes the task force recommendation on screening for latent TB, as well as the evidence report on which the task force recommendation is based. Dr. Ogedegbe, welcome, and thank you for joining us for this discussion today.
Thank you, Kirsten, for the introduction, and thank you for having me today.
Wonderful. So if you don't mind, if you could start by telling us, give us the top line of this recommendation statement on latent TB.
So consistent with the 2016 recommendation, the task force continues to recommend that people who are at increased risk for tuberculosis be screened. That is our top line. This recommendation is a grade B recommendation.
Great. And so A and B recommendations for the task force are really ones where the evidence is there, and in this case, the evidence is there to tell us to screen for latent TB. Why don't you give us an idea about how big a problem is this in the U.S.? We know TB is a big issue worldwide, but how come we're thinking about this in the U.S. context?
I think when we think about this for the U.S. population, because the prevalence is about 5% in the U.S. However, if you look at people who are exposed to anybody with active tuberculosis, about 30% of such people will actually have latent tuberculosis. And of those, you're looking at about 1 in 10 people that may go on to develop active tuberculosis. So it's a public health problem that is pretty significant.
So the prevalence is there, and then as with many things with the task force, people walking around with no signs or symptoms of disease who then can have it reactivated.
Correct. So there are basically two types. So we're looking at people with who we call have latent tuberculosis infection, or if I can just use the term LTBI. The idea here is that they have bacterial infection, they're not contagious, and they have no signs or symptoms of the infection. However, if left untreated, that may go on to progress to active tuberculosis. So the task force is recommending that such people will be screened, because particularly those who are at increased risk for TB.
Great. And so you said that we should be screening because there's risk that this TB that represents infection that is latent could in the future become active infection and really be a problem for that person. The recommendation statement is really focused on people who are at high risk. So it isn't screening everybody. Give me an idea of how we think about risk in this context.
Great question. So people who are at increased risk here actually includes maybe 3 sets of people. Those who were born or who have lived in countries that have high burden of TB. Those who have lived in certain group settings, like prisons and homeless shelters. These are the people who are considered to be at increased risk for tuberculosis.
And did you say that there were 3 groups?
Actually, 2 groups, actually. The third group, that is part of people who are immunocompromised. Those will be those with HIV, if you may, or with cancers. But those people, that will be part of their regular treatment anyways.
So because those people who are at particularly high risk of progressing, people who have cancer or people who are immunocompromised, they really have separate recommendations. So I think you're very much focused here on people who, because of where they were born, where they grew up, the settings in which they live, they put them at higher risk of having been exposed to TB at some point.
Correct. We're looking at those 2 groups.
Wonderful. And would you give me an idea of which countries are we talking about?
So several countries, if you look at the data, it turns out that majority of people with TB in the US today come from 5 countries, Mexico, Philippines, India, Vietnam, and China. So really, these are the most common countries of birth among people with TB in the US. The key factor to appreciate here is that about 70% of people with TB, at least in the country, in the US, they're immigrants who come from those countries or who were born or lived in those countries.
Great. But what I also understand is that there is some variation. So while when we consider the whole country, most of the cases of TB are coming from people who have spent time or were born in those countries that you mentioned. So really important to highlight. But there's also a feature that you have in your recommendation statement that you really should pay attention to what your local public health department is also saying about the risk in people who are living in your area.
That's I'm glad you're asking me to clarify that. So let me be very clear here that the reason we're looking at people who were born in certain countries is because over half of the folks who have active TB today actually migrated from those or have lived in those 5 countries I talked about. But that said, given the dynamic nature of immigration, it's often very important to contact the local departments of health or even the CDC side to appreciate what the local prevalence or what the local nature of that will look like.
And you have also highlighted that regardless of where you were born or where you have lived most recently, if you're living in a higher risk congregate setting, you might also be at risk and somebody who we should screen for latent TB.
Correct. Those will be those who actually probably lived in prisons or in homeless shelters. It puts them at increased risk as well.
So one of the things that was pointed out here, so we've now talked about who's at risk. But one of the things that was pointed out to me in this recommendation statement, and I found really interesting, is that you've really highlighted different types of screening tests, 2 types of screening tests. We probably are all very familiar with the skin test that we oftentimes use for TB screening, but the recommendation statement is making statements about different types of tests.
Correct. There are 2 types of tests that we're making recommendations about. One of them is the skin test that you just talked about. It's called the tuberculin skin test. And the other is the IgRA or interferon gamma release assay. The key thing is that it's a blood test. And I think it's important to appreciate that both tests do have pretty decent accuracy in the detection of people with latent TB infection.
Great. So we could use either test to be screening?
We could use either test. There are several things to consider, which we actually put in the recommendation, is that in deciding which of those tests to use, the clinician has to appreciate that, several factors. One is, when you think about it, for the skin test, people have to come back, right? At least about 2 days to see whether or not their test is positive. For the blood test, they don't have to do that. It's important to appreciate that, can the facility where they're getting screened, do they have the resources to actually get those tests back in a timely manner? Or in the other case, if the patient really, you may see some patients who don't have the time to come back for testing. You may want to decide as a clinician which test to provide to such patients. So it's important to appreciate when and which type of test you want to use, given either the patient's situation or whether or not you have the resources in the testing site to actually make sure you can get those results back in a timely manner.
So, as is often the case when we're talking about screening tests, the most important test is the one that actually gets done. And in this case, you've given us a variety of different ways to think about why one might be a test that gets done in a particular facility or for a particular patient. So oftentimes there are gaps in the literature. Are there some gaps in the evidence base that we have here that you should be telling our scientists about that we need more information on?
Yeah, there are several gaps that we identified and we called for more research in those areas. I think we have 3 areas there where we specified. One is that we don't know what the threshold is, right? For screening, should it be annual? Should it be less frequent or more frequent than that? It's important for the clinician to use their clinical judgment, determining whether or not the patient's exposure risk warrants them to screen that patient yearly. So that we're calling for more research in that space. The other thing that we're calling for more research on is we need to understand which tools can help us better identify people at increased risk. We think that's very important. And then finally, it's important to appreciate that we're calling for more research to appreciate the screening strategies that are out there and which are the ones that can better help us identify folks at increased risk.
So a clear message, the evidence is clearly saying that we should screen, but we still have questions about how often, and we need more information about how we really identify the people at highest risk so that we are focused on them.
Correct.
Wonderful. Do you encounter this issue in your practice?
Now, I work in New York City. I live in New Jersey. And so where I practice is Bellevue Hospital. That is a public hospital. And as you can imagine, New York City is really the melting pot for people from many, many countries. So we encounter this all the time. It's a staple of our practice.
Yeah, and I similarly practice in San Francisco at the public hospital. And certainly we're very focused on it, have big immigrant communities, but probably the one that has always been important for me as I think about in my practice and where I've been caught off guard is those patients who have a history of living in a congregate setting that puts them at risk. And I think I've gotten very used to thinking about exposure because of where you might have grown up, but the congregate settings is such an important one also in the U.S. that I think many can overlook.
Yes, actually for Bellevue, we have a shelter pretty close to our hospital system. And so a good number of my patients around the hypertension clinic there as well actually come from that sector. And we have systems in place to actually screen them pretty regularly. That's a great point.
Well, Gbenga, anything else you'd like to tell our listeners or what you would like to reinforce in this important recommendation?
I think I'd like to reinforce several things. One is that this recommendation is actually targeted adults 18 years and older, right, who are at increased risk. And it's important to appreciate that the screening that we're proposing here is pretty effective in identifying the infection so that it can be treated before it progresses to active TB. Finally, I should say that this is a bacterial infection that is treatable. And we know that the CDC has several recommendations of active antibiotics that can be used for the treatment of tuberculosis, as well as those who have latent TB infection. Also, it's important to appreciate that TB is diagnosed through a combination of medical history. So if somebody tests positive for TB, it's important to follow that up with clinical assessment, physical examination, and a diagnostic workup to confirm that diagnosis.
Wonderful. We didn't really talk much about the treatment, so I'm glad that you brought that up. The point I think you are making, I'm just going to underscore, is that by identifying people who have latent TB, there are a number of treatment regimens that are tolerated and can be initiated in order to prevent someone from having active TB. And it's nice to see this recommendation feed in with others that are out there to ensure that the screening then leads to treatment with the appropriate regimens.
Correct.
Well, Dr. Ogedegbe, it's been a pleasure. Thank you for joining me here on this JAMA Clinical Reviews podcast. I've appreciated the conversation and look forward to more from the task force.
Thank you, Dr. Bibbins-Domingo, for this as well. Truly a pleasure.